Warren, and I am presenting on behalf of the APPHC Partnership, co-led by Breakthrough Research at Population Council and the HERD project at URC. As many know, maternal health providers work in challenging environments, often with limited support, but a provider's mental health and well-being can influence the quality of care that they deliver. It is essential that we better understand how different factors lead to burnout in order to support providers in their work. As part of the broader APPHC portfolio of research, this study looked at the influence and relationships between providers' mental health and RMC at 2 time points. Maternal health providers often experience traumatic events such as maternal or fetal death, causing sadness and grief. Other critical incidents, but less serious than death, can be mentally draining and disturb a provider's sense of peace and purpose. I will not go into all the details, but will summarise some of the key issues that we found around RMC and burnout in Malawi. We measured provider RMC scores using the provider self-reported provision of the person-centered maternity care scale. See some of the questions in the bar chart on the right. There are 15 items with a 4-part response pattern ranging from never to always. To measure burnout, we adopted the Mass/Burnout Inventory, or the MBI, used globally to measure burnout. It has 3 different dimensions: emotional exhaustion, depersonalization, and professional accomplishment. We used the MBI at baseline and endline, but only added depression and PTSD at endline survey as a request by stakeholders in Malawi. At baseline, we found that a quarter of providers experienced emotional exhaustion, including feeling working too hard, felt very tired, or feeling emotionally drained. By endline, the proportion of providers experiencing emotional exhaustion significantly increased to 30%, and the prevalence of depersonalization nearly doubled. These high levels of EE and DP at endline may be related to the COVID-19 pandemic. Our baseline was collected just before the pandemic started in Malawi. We found that those providers who had high emotional exhaustion or depersonalization reported lower PCMC scores. These providers were also less likely to always assess for pain, explain the procedure, and never abuse a patient. Here also you can see that increased depression and burnout scores were correlated with reduced PCMC scores, although PTSD was not associated with PCMC. Providers face an array of mental health challenges, with clinically significant depression at 7.5%, most prevalent at lower levels. PTSD was high among clinicians and at community hospitals, and suicide ideation was again most prevalent among clinicians, but also at the primary healthcare level, possibly among providers who are working alone. There was, however, new recognition that burnout does affect many people, as seen in the quote. On issues of PPH, we have learnt that as health workers we have burnout. We have learnt ways of handling that, and the issues are cross-cutting for everyone, because at first I thought maybe it's only me who meets these challenges at work. One thing that became apparent was that most providers felt they had good supportive relationship with their supervisors and managers. Really, everyone should agree with these statements on the right here. But up to a third either feel their manager doesn't treat them with kindness or are ambivalent about it. Further work is needed to develop an evaluative measure of workplace relationships and culture. To highlight the influence of support as management scores increase, we see a decrease in emotional exhaustion, depersonalization, depression, and of course an increase in PCMC scores. However, PTSD was not significantly associated with these management scores. To better understand how the mental health status and work experience of healthcare workers influence the care they provide, we conducted a path analysis using provider-reported RMC as the ultimate outcome, and we used the same. For measuring RMC, we used the PCMC scale. Both depression and emotional exhaustion component of the MBI have a significant direct inverse association with RMC scores. As depression and/or emotional exhaustion increase, our RMC scores go down. We also examine mediating effects. These These are factors that do not directly influence RMC scores, but instead exacerbate the effects of depression and emotional exhaustion. In this analysis, we found that the MBI depersonalization domain strongly influences depression. As depersonalization increases, so does depression, which results in reduced RMC scores. While this is the strongest relationship in this pathway model, depersonalization has no influence on emotional exhaustion. Conversely, we found that PTSD has a significant association with depersonalization, depression, and emotional exhaustion. This suggests that PTSD has wide-ranging, non-specific effects across numerous aspects of a provider's mental health and well-being. Finally, despite the detrimental effects of increased levels of PTSD, burnout, and depression on RMC, we also found that a provider's relationship with the facility management, that is, how the facility supports their staff, can have a powerful protecting effect in this situation. Not only do positive supportive relationships with facilities show a direct positive association with RMC, positive relationships with facility management also appear to mitigate the effects of both depersonalization and emotional exhaustion. Thanks to Brady Zeman at Pop Council for doing this analysis and developing this pathway. So in summary, we have started to understand in more detail the influence of providers' mental health and well-being on the quality of care. We have documented that depression and emotional exhaustion influence RMC directly, and depersonalization has a strong positive correlation with depression. But we have also seen that strong supportive relationships with the facility can mitigate the effects of burnout, and that where providers are involved in identifying solving their own challenges, their self-efficacy also improves. I know many have recognized these challenges for a while, but we really do need to consider providers' mental health in any interventional program to improve quality of care. Thank you.